I'm here to talk to you about molecular imaging of fibrosis, and we've done a little bit of work in the heart, but a lot of work elsewhere, as you'll see, and I think there's a lot of opportunities here. I do have some disclosures, which are here. And I got interested in this work, I'm in the Department of Radiology, and when you look at fibrosis, which of course is a common sequelae of a number of chronic diseases and acute diseases, we have very poor tools in radiology for looking at fibrosis and for staging it. The ones that we do have generally work better for advanced disease. And we, to my knowledge, we don't have a very good non-invasive way to distinguish active disease from stable scar. In most cases, biopsy remains the gold standard, and of course, there are a number of problems with biopsy from a morbidity, mortality standpoint, also the inability to repeat sample and get access to the whole tissue, to the whole organ. So we started this work some time ago, and we identified a peptide that was specific to type 1 collagen. And I was interested in type 1 collagen because we were looking at fibrosis and what's the most, when you stain for fibrosis, you're doing collagen stains. And I'm not a clever molecular biologist, so I just looked at where were the trees in the forest and just try to image the trees, which was collagen. And the reason, though, for looking at collagen was something that we can see with MRI. So with MRI, we typically need high concentration targets, and collagen actually works quite well for this. So we made a few compounds, this one's shown here, and then we can also just change the amino acid, the chirality of this cysteine, and this knocks out the affinity for the target, and it works as a nice negative control. So, I dug up some old heart slides, and so this is in a mouse model of old myocardial scar, about 8 weeks after MI. So this is just a black blood image to orient you, and then what we do is we do a trick with MRI where we do an inversion pre-pulse, and we can null the signal in the myocardium. This is just like zeroing your spectrophotometer. We inject the probe via the tail vein, and now the blood pool becomes bright. And then if we image serially over time, here's an example of an image now at 40 minutes post-injection, and you can see this really nice enhancement of the scar. And then we can take the identical probe, except where we've modified one of those amino acids from L to D to knock out binding, and take the same animal the next day. Here's the anatomical image to orient you. We null the signal in the myocardium. We inject the probe. The blood pool is bright. But over time, it washes out, and there's no enhancement of the scar, and this is one way that we look at specificity. And when you do this, you can compare the MR imaging with, in this case, picroserous red staining, and look at the circumferential extent of fibrosis in these animals, and you see this excellent one-to-one correspondence, and of course, this is why we do non-invasive imaging, so that we can get the same information without having to take the heart out of the subject. We've applied this, we've got very interested in liver fibrosis, especially in the context of NASH. We've been doing a lot of work in this area and really trying to look at staging of fibrosis. And this is an example in a model of biliary stasis. So this is when you ligate the common bile duct. And what I'm showing here is so these are relaxation time maps before and after we give the probe to an animal that's had its bile duct ligated, and you can see a big signal change here in the liver. An animal that underwent a sham procedure, you see very little signal change. And then we can quantify this over the whole liver, and that's what these histograms represent. So this is before injection and after injection, and the difference between these two maxima is directly related to the concentration of the probe. So we can quantify how much probe is present in the liver and its distribution in the liver, and then we can see how that relates to extent of fibrosis. And so in this model, it's quite nice. If you image animals a few days after bile duct ligation, they already start to have a mild fibrosis. After 10 days, a more moderate fibrosis, and by day 18, the fibrosis is quite severe. So when you do this, you can generate these sort of receiver operating characteristic curves. So this is a tool that we use if you're not familiar, looking at sensitivity of, just a way of characterizing diagnostic tests. We're looking at sensitivity here and 1 minus specificity on the x-axis. And what you want to see is a test that gives you an area under the curve of close to 1. The dashed line here would represent if I just flipped a coin, and that was the result. And what we're comparing to here is digital pathology, so the extent of fibrosis. So this is looking at no fibrosis versus any fibrosis. This is looking at severe fibrosis versus moderate or mild fibrosis. And then with that, we then went on and looked at treatment in these animals, in this case with rapamycin, which had been shown in the literature to prevent fibrosis in this model. And what you see is that we indeed can blunt the fibrosis when you give rapamycin, but if you look at the range in these box plots, what you see is that it looks like, both from pathology and from our imaging, that we have some animals that responded well to treatment and some animals that did not. And then what we could do is use this ROC curve and prospectively use this information and say which of these animals, based on our diagnostic tests that we previously defined, have severe fibrosis and therefore did not respond to treatment. And when we do that, we can separate, again in a prospective and objective manner, non-responders from responders. And this is confirmed again with histology. Another interesting thing I'd like to highlight from this study, especially with my hepatology colleagues, is this was an animal that actually underwent a partial response, and you can see here in the liver beforehand that all the liver looks the same, but after injecting the probe, the right lobe, you see a big change in signal, but not in the left lobe, which would indicate that the left lobe, you had a response to treatment there and not in the right. And that was confirmed again with histology. But we can quantify now over the whole organ, again with these sort of histogram plots. So this is the area under this. It would be the region of the liver that responded to treatment, the area under this, the region of the liver that did not respond to treatment. And obviously, if you're biopsying a liver like this, you'd get very different results depending on where you put the needle. So I'll also show you some work with this probe in a dog model of diffuse fibrosis that we've been collaborating with Ray Kim's lab at Duke. And this is where they're embolizing different numbers of microspheres down the left circumflex, either through the OM1 branch or just directly through the LCX. They image 6 to 8 weeks after embolization. And then they're comparing conventional delayed enhancement MRI using standard gadolinium to CM101, which is our fibrosis imaging probe. So this is an example of fibrosis in the lateral wall and the anterior papillary muscle, which is left off here. And so you can see with conventional delayed enhancement imaging, you can pick up the fibrosis here, the enhancement here in the lateral wall, a little bit here in the papillary muscle as well. But it becomes much more clear with these slices using the targeted contrast agent, and you can also appreciate the heterogeneity in the fibrosis that one can see here. In another example, just this is an animal that got fewer microspheres directly into the LCX. And this is a case where now you can see what looks like there might be there may be some fibrosis here in the wall. Again, much more clear with the targeted contrast agent. And then in this two-chamber view, the delayed enhancement really doesn't pick anything up. But again, we can see these subtle changes with CM101. So that was looking at sort of total fibrosis, and I gave you some examples of sort of fresh accumulation of collagen and old scar, and so we also wanted to ask the question: can we distinguish active disease from old scar? And if you look at think about the biology of fibrosis and fibrogenesis, one of the key features is collagen cross-linking. So you have an upregulation of lysyl oxidases, which are converting lysine side chains to allysine. And then this is, of course, a catalytic process. But then these aldehydes that are formed undergo condensation reactions either with themselves or with amines in a slow and reversible process. And then these undergo further reaction to form these irreversible, stable crosslinks like this desmosine moiety here. And so our thought was that during active fibrogenesis, would there be a pool of extracellular aldehyde that builds up in tissue? And then if the insult goes away, LOX becomes downregulated. We're not producing any more of this, so it eventually gets consumed into crosslinks or degraded by MMPs. And so we developed an assay for this, and at least in the lung, we can show that indeed during fibrogenesis we see very high concentrations of allysine in the matrix and at levels that we can detect by MRI. So this is an example of our first prototype probe where we made this gadolinium small molecule complex that has a hydrazide group which combined covalently and reversibly to allysine. And as a control, we made the dimethyl version, which of course cannot undergo that condensation. So if you take something like BSA, which is a very lysine-rich protein, it doesn't bind to BSA, but if you oxidize the lysines on BSA, now it binds. The control probe doesn't bind to either. And then I'll show you some slides now in a model of pulmonary fibrosis, and this is where one gives bleomycin intratracheally to induce fibrosis. And so this is 2 weeks after bleomycin instillation when there's active fibrogenesis. And so I'm going to show you images with a color overlay. So the color overlay is simply the image after we give the contrast agent, subtracting the baseline image to show you the effect of the probe. And so when we give the active probe, we see a lot of signal in the lung. When we give the control probe, we don't see any signal in the lung. This is quantified here over a group of animals, and then also comparing to sham-injured animals as well, showing, again, the specificity. So we were interested then in seeing if we could look at a sort of a treatment response effect and also to probe further the specificity. So if you injure these animals with bleomycin and then start treating them with beta-aminopropionitrile, which is a pan-lysyl oxidase inhibitor, and you look at the tissue and on day 14, and you measure lysyl oxidase activity in tissue, it's completely inhibited by BAPN. And this, of course, inhibits the production of allysine in the tissue. And our imaging can pick this up quite nicely. So to get to the point of looking at active disease versus scar, we then ran this model out further. So now looking in the lung here of sham-injured animals at 2 weeks and at 4 weeks, if we measure how much collagen is present in the lung by looking at hydroxyproline, you can see that there's still very high levels at 4 weeks. But LOX activity is now starting to decrease at 4 weeks. And likewise, allysine is going down at 4 weeks. And again, we can pick this up nicely with MRI. So we think we have a good marker of this pharmacodynamic effect. If you're a chemist, you realize that there are many ways to target aldehydes. We made an oxyamine derivative, which reacts faster and forms a more inert bond with an aldehyde to form an oxime. This resulted in an improved performance. I won't go through this, but just when we do increase the reactivity, we do get a stronger effect. But also by going to an oxime bond, it keeps it associated with the matrix a bit longer and now allows us to do something like imaging the kidneys. So this is some examples from a collagen 4 knockout model. And these mice develop glomerulonephritis with microhematuria, proteinuria, fairly consistent with human disease. And to show you, in this case, what we do is we inject the probe and then we wait 4 hours for it to clear the kidneys and then image. And so if you have, in this case, a heterozygous animal, and we look again at these sort of histogram maps before and after, they line up the same, and there's really there's no enhancement in the kidney. If you have now some mild fibrosis, unfortunately these don't project very well, you can see now a shift. And if you have more severe fibrosis, you see a bigger shift. And you can, both in the cortex and the medulla, you can see big changes between wild-type animals and the knockouts. You see big changes in hydroxyproline levels, which is a marker of collagen in the cortex and the medulla. And we see a very nice correlation between the extent of disease as measured by measuring total collagen in either the kidney versus the MR readout. One can even take this another step further and think about making more irreversible binders. With MRI, of course, we're giving a large dose, and we want that dose to eventually be eliminated. If we go to something like PET, where we give subjects a few micrograms of material, we can essentially make an irreversible binder. And so here we adapted some chemistry from Caroline Bertozzi's group, this pictase Spengler ligation, where this indole makes this oxime very reactive. As a control, we reacted this with formaldehyde to give this carboline product. If you look at the aorta, which is one of the few tissues where you actually have high levels of lysyl oxidase because of the constant remodeling, you see, and there the aorta is allysine rich. So our active probe binds quite well to aorta. If you pre-treat the aorta with an aldehyde blocker, then we see very little uptake, and the control probe doesn't bind to aorta. Again, going back to this bleomycin injury model, with the active probe in the injured mice, we see good uptake in the lung, but not in sham-treated animals, and not with the inactive probe. About a 7-fold now increase compared to sham-treated animals or compared to the control probe. And again, we see this very nice linear response with here measuring allysine in tissue ex vivo and comparing to the amount of radioactivity we get in the lung. So a very, very good way to quantify disease. We can also look at type 1 collagen with PET. This is a similar type of example here, again back in the lungs, and again showing that with the active probe in diseased animals we see signal. And if you look across other tissues with our active probe and our control probe, we see a very similar distribution in the tissues of mice, whether they're bleomycin injured or not. And the only one that's different is in the lung, where we have the active probe getting high uptake in the diseased lung. You can also look at treatment in this model. So in this case, what we were looking at is treating these mice with an anti-alpha V beta 6 antibody from Biogen, and you can see here from the PET imaging that the signal is strongly reduced in the treatment group. If we treat these animals with an irrelevant antibody, the signal is high. The antibody, it's a little hard to see from these serious red images, but if you look at quantifying fibrosis by collagen levels, it's significantly lower in the treatment group, and the PET can track this as well, and again in a very linear fashion. We've taken this probe now and with reams of paper started doing human imaging. This is just looking at the distribution over time. So you inject the probe and it clears very rapidly. It has about a 35-minute blood half-life, clears mainly through the kidneys. You can see the bladder filling up here, and very low levels in the lungs and also in the heart. So these are some PET-MR images of a healthy volunteer and a patient with idiopathic pulmonary fibrosis. This is the HRCT of the IPF patient for comparison. So you really see very low signal in the lungs of the volunteer. That's the aorta here. And this is the extent of disease here on CT. It's a lower lobe predominant disease. And so we see that, we pick that up here nicely as well with PET. And around here. But what we also see with PET is regions now further along the subpleural area going into the upper lung and regions here of higher intensity in otherwise radiographically normal lung, where we're hoping that this corresponds to earlier disease. The probe works quite nicely. If we've taken subjects, had them come back within a week and get imaged again, and this is looking at the signal in this case in the left lower lung on one day, and then at the second imaging session, and really excellent repeatability. And so really where we want to take this now is to look at both disease progression and response to treatment, because we've got a very nice coefficient of variance there. So with that, I'll wrap up. So hopefully I've convinced you that molecular imaging is feasible. We've got a couple of ways to go about it, looking at fibrosis burden and fibrogenesis. I think with the molecular approach, we're very sensitive to early stages of fibrosis. We have a number of examples of that. And this imaging can be done quantitatively. There are a number of applications beyond things like detection, but also quantitative staging, monitoring treatment response, prognosis, especially important in diseases like IPF, identifying patients who will benefit from certain treatments, and also for enriching clinical trial enrollment. Work with a great group of colleagues at the MGH, and also this nice collaboration with Ray Kim's group at Duke, and we're very grateful to a lot of support from the NIH over the years and from the MGH itself. Thank you.